Okay, carrying on from slide 84. Another clinical tip for you, it's not a bad idea to check your patient's occlusion using articulating paper while you're waiting for your anesthetic to take effect before you put your rubber dam on, before you've started your restoration at all. So this is for a couple of reasons. One, because you can visualize with the blue dots from the paper on your cusp tips and everything exactly where you're expecting your occlusion to get back to after you've completed your restoration, but also because, especially if you're numbing up the lower jaw, patients find it quite hard to get into centric occlusion when half of their mandible is numb. So usually I ask them when we're testing the bite after I've finished and we're taking the rubber dam off, okay, very gently try and find your normal biting position. It'll be more obvious on the non-numb side, just gently tap, tap, tap sort of thing. Like I said, if it's too high and they close too forcefully on it while you're trying to check the bite, then you'll risk crunching off. Maybe your marginal ridge is probably where it's most likely to be high, and that's a real drag after you've just spent so long trying to do a good job. So it takes about an hour for the material to be strong enough to withstand normal occlusal forces. I routinely ask my patients to wait until the numbness is worn off before they chew anything anyway. That's soft tissue post-op instruction protection, obviously. But even though the tooth-colored filling materials are ready to rock and roll in terms of biting quite soon after they're placed, yeah, I think one of the best pieces of advice I can give you is try and get into habits and routines with the way you explain things to patients, and that way you're less likely to forget to say something, one time. So standardly, if you've done a restoration under LA, ask them to wait until the numbness is worn off before they try and chew anything. That'll generally cover the instruction that goes with amalgam to wait at least an hour before they try and use their teeth for chewing as well. So it takes about 24 hours for it to come to its maximum strength. I often add that as well. If I've just done one, I'll tell the patients not to chew super hard stuff until the following day. So it says that the restoration should be finished post that 24 hours of full hardening. But I've also got a note here that there's no advantage to finishing a restoration 24 hours later if it was placed correctly in the first instance. So yeah, I don't routinely get patients back in. Obviously, if there's a big overhang or big occlusal adjustment that I'm going to need a rotating handpiece to modify, then I'll do it at the next appointment. And if it's so ridiculously high that your patient is only chomping down on that amalgam restoration and it's propping the rest of their mouth open, I would ask them just to stick to soft foods until they could get back in to see me the next day. So apparently using a slow speed stainless steel burr in reverse is a good way to finish/polish restoration 24 hours later. I've never tried that, but we can definitely have a play around in pre-clin if you like. So here's the pictures of the flutes on the left-hand side. Those would be the slow speed stainless steel burrs I just mentioned. On the right-hand side, these are called shofu burrs. They come in high-speed and slow-speed versions of each shape. The brownies, or they're called brownies, are the more coarse of the finishing texture, so they're used first, and then the greenies after. Okay, so we're going to talk a little bit about physical and mechanical properties of amalgam, and really what's important for you to know is the strength and physical properties of amalgam compared to other filling materials and compared to dentine and enamel. So this information is for you to be able to apply clinically. You don't need to like regurgitate the numbers, although having an idea of how much stronger they are than the other materials will be beneficial for you. So compressive strength, I'm not sure if you guys are aware how much force people apply during function, but it's significant to know that people apply a hell of a lot more force to their teeth when they're engaging in a parafunctional activity. So like clenching or grinding, you apply, I think it's almost twice as much force occlusally during those activities than just during normal function, which is pretty extreme. So here's a table with compressive and tensile strength properties with all the things you need to know there. So amalgam has much stronger compressive strength than even enamel. And if you ask me in our next lecture to give you the example of fractured cusps and how I normally explain that to patients if they've got an amalgam occlusal restoration, I'll draw you a bit more of a diagram next time I see you. So modulus of elasticity is, let's just go back to the last slide briefly. So compressive strength is obviously how much strength the material can withstand in a compressive direction, and tensile is it's about the description of how much stress you can apply before the material breaks. The modulus of elasticity is more to do with what change in length is the term I have here, per applied force. So it's very similar to tensile strength, but it's like how bendy it is. Basically, the lower the modulus of elasticity, the more flexible a material is, and the higher the modulus of elasticity, the more brittle the material is. So in order, GIC is the most flexible, followed closely by composite resin, and next dentine. So glass ionomer cement has a modulus of elasticity of about 3 to 5, and resin composite is about 4 to 16, and dentine is 18. And then we have quite a big jump up to amalgam, which is 55, and then enamel is the most brittle, which is about 80. So basically, the clinical relevance there is that amalgam is quite brittle and it will fracture in thin sections. Fatigue strength, how many times you can bash at it before it fractures. High copper amalgams are pretty resistant to fatigue over time, so they last ages. Dimensional change, we talked before about zinc-containing amalgams, which may exhibit delayed expansion 3 to 5 days after placement. That's because the electrolytic reaction between water and the zinc, which generates hydrogen gas and leads to expansion. Now with the low zinc amalgams, the dimensional change is clinically negligible. So thermal expansion is low in amalgam compared with other materials. Composite resin is equal to about 60, which is one of its major disadvantages. So thermal expansion is sort of, if it gets cold, how much does it contract? If it gets hot, how much does it expand? That sort of thing. And with composite resin, that's what can cause it to debond if people are drinking, really cold stuff, or ice water, that sort of thing, ice cream, swishing it around in their mouth. Same with really hot foods. Some people like to do that. So creep. I'm not sure if you've heard of creep before. It's a kind of interesting property of amalgam. It kind of creeps its way out of its prep over time. Its official definition is deformation after occlusal loading. High copper amalgams have less creep than the older low copper amalgams. The addition of palladium has been shown to improve compressive strength and creep resistance, and apparently decreases the release of mercury over time as well. So you can see here on this kind of grainy picture that the tips of the margins there have sort of crept out and have these little overhangs on the occlusal surfaces, and because those are thin, that's what will fracture off and then lead to sort of a marginal deficiency. I want you to think about just now, we'll talk more about this later, and it's one of my suggested topics for your case study presentations, is if this was the only deficient part of the restoration in a low caries risk mouth, so this wasn't plaque trapping and you weren't worried that secondary caries was creeping underneath this restoration, how do you manage that? What do you do about it? You can't bond amalgam to amalgam. You can't bond composite to amalgam. But you're not super worried about plaque collecting in this area in some circumstances. If your patient's got good oral hygiene and a good diet, what do you do about it? Wear. Slightly more than enamel, slightly faster than enamel. Over a 10-year period, this would only add up to 0.1 to 0.2 of a millimeter more than enamel. But this is accelerated if someone's got a high occlusal load. So if they're parafunctioning, basically grinding, clenching, it'll happen faster. Corrosion. We talked a little bit about corrosion and the self-sealing properties of amalgam. It's used to be cited as the most important property influencing clinical longevity because secondary caries is the most common cause of failure. We talked a little bit about this previously. Secondary caries is the most common cause of failure of any restoration, and sort of highlights the importance of us making sure we're only really doing restorative treatment in people that are interested in reducing their risk status from a high caries risk to a low caries risk if they're not already. So we could definitely spend our whole working lives just maintaining the dentition of people who are low caries risk. And yeah, it's a problem. Okay, tarnish. Tarnishing is basically surface corrosion. It's not ideal. Crevice corrosion, that's what we were talking about before. Galvanic corrosion, this is a kind of interesting one. So saliva sometimes acts as an electrolyte between different metals in the mouth. That could be amalgam and gold. It could be amalgam and part of an alloy from a prosthetic, like a partial denture. It could be between an old amalgam and a new amalgam. It could be between an amalgam and a fork. It could be between a metal piercing in the mouth. And yeah, it can feel really strange. It's like zapping, a battery on your tongue, sort of thing. It's like a little electrical circuit going on. When crevice corrosion occurs, the galvanic action decreases. So it tends to only happen in fresh amalgams as such. Indications of amalgam. Basically, it's still the strongest direct filling material that we have. The only thing we have stronger than amalgam are indirect restorative materials, so things that you use in fixed prosthodontics, like so your ceramics and porcelains and cast gold and that sort of thing. This picture is someone who's suffering from a lot of different types of wear. These are very, very difficult cases to manage because nothing is, there's a lot of restrictions here in terms of what restorative materials you can use. Here, this is a crown. You can sort of see that the color is a little bit different to the rest of the enamel that we can see there, and there's a little line of metal underneath, so that's a porcelain bonded to metal crown. I don't know how much you guys know. I'd love to have a conversation maybe in our next lecture about different types of wear, so attrition, erosion, and abrasion. I mean, indirect restorations are good and they have a place. Generally in the public sector we don't use them. There's not many places in Victoria in the public sector that make indirect restorations, so often you're limited to material choice by our direct materials. And in the private sector, it costs about 10 times more to place an indirect restoration than a direct one. So that can be prohibitively expensive for a lot of patients as well. So let's move on. Contraindications. So yeah, just to summarize that last slide, the indication, an unинdication for use of amalgam is when maximum strength of a direct restorative material is necessary. So, and when complete moisture control can't be obtained, that could be because the restoration is bordering on being subgingival, so like equigingiva. You guys won't be placing technically subgingival ones, but sometimes in mouths that have had a lot of recession and the bottom of your proximal box prep is lower than the level that enamel is at. So it might not be subgingival. It might be that people are a little long in the tooth, if you know where that expression comes from. You know, they've had the recession, exposed root surface, and so it could be that the margin is on the root surface, but that's still supragingival. You're not going to get super good bonding between your root surface and composite in that case, so that might be one of the reasons why an amalgam is a good choice. We can talk more about that in another lecture. So contraindications, if you have a small carious lesion and you would have to expand the size of your prep significantly just to make it big enough to place a composite, so like I said before, a 2 mil by 2 mil by 2 mil, if that's significantly bigger than the caries that you've just removed, then I would say it's not minimally invasive to put an amalgam in that situation. The other contraindications, the main one is if you don't have consent from your patient to place it, which can be a bit more challenging. So I want you all to think carefully and practice the examples that you can use when talking to your patients about why you're okay with putting an amalgam in their mouth. And you can definitely approach it like, if it was my mouth, I would have amalgam for these reasons. This is why it's good. This is why you don't need to worry. And at the end of the day, if it's an aesthetic concern, then your hands are kind of tied because, that might be your deciding factor, or it might be your patient's deciding factor. So one of the advantages of placing amalgams are that when it comes time for them to be replaced, and I say when, not if, because all of our direct restorative materials have a lifespan. None of them are forever materials. So when it comes time to remove the restoration, you can see it a lot better than trying to remove composite. I don't know if any of you have tried to remove a composite, especially one that's well color matched to the tooth that you're working on. It's extremely difficult. And so there's less chance of enlarging your prep when you're removing an amalgam as opposed to a composite. Longevity-wise, the long-term studies show that amalgam lifespan is about 10 to 15 years compared to composite, which is 5 to 8 years. But there's other studies showing that composites have a more comparable longevity. And I think it comes down a lot to clinical decision making and using it in the right situation and having good moisture control and what your patient's risk status is. That's more important at the end of the day. You can place amalgam in thicker increments, so to speak, because you don't need your curing light to reach, all parts, obviously. It's low technique sensitive. It's got low technique sensitivity because there's less stages to go wrong compared with composite, where if you don't do everything right, like your etching and your priming and your bonding and incremental placement and curing, this you kind of just whack it in and push it in and Bob's your uncle. And it can be faster for the same reason. Disadvantages: if your cavity is small, excess tooth structure needs to be removed for retention, not minimally invasive, need to have consent, and lots won't give it because of aesthetic and toxicity concerns. Toxicity, we haven't talked much about that yet. Okay, so the most dangerous form that mercury takes is vapor. So the liquid mercury, which is its elemental form, has little or no toxic effect when swallowed, and it is poorly absorbed and passes easily through the gastrointestinal tract. So this was more of an issue back in the day when people were hand mixing amalgams before we got the amalgam mixers. So toxicity occurs when mercury in its vapor form is inhaled. And this is why it's so important to use the high velocity suction and PPE when you're using amalgam. Ironically, the vapor occurs like an aerosol when polishing, finishing, and removing amalgam restoration. So I'll talk more in a second, but technically the biggest concern about mercury in amalgam is as an occupational hazard, because we're obviously exposed to that on a daily basis as opposed to patients that are only exposed to it once in a while. Dental amalgam contains several inorganic mercury compounds that are not so concerning. Inorganic, sorry, I'm not sure what I said there. The organic ones are the methyl and ethyl compounds are the nasties. So I used to often use this example, sorry if I'm repeating myself, from the lecture the other day. I used to frequently use an example with my patients that, you actually consume way more mercury just from eating a deep sea fish than you do from having a bunch of amalgams in your mouth. And then I found out recently that the fish have mercury in them because of poor amalgam waste management, which led to the amalgam and the mercury being in our water supplies and water systems. And if you're familiar with the biomass pyramid, basically the amalgam waste into waterways, the methylate and ethylate were metabolized by the smaller fish, which were then consumed by the bigger fish, and the concentration increases as you go up the food chain, basically. So by the time we're eating the big fish, we're consuming concentrated amount of mercury. So yeah, so it's true that you consume more mercury from eating fish than you do from having amalgam restorations in your mouth, but unfortunately that's because of dentists in the scheme of things anyway. So these are things that can increase the amount of mercury coming from your fillings, not by a significant degree, however. Like I said, polishing is one of the worst ways to get the mercury into vapor form as an aerosol. So definitely important to use lots of water spray, high velocity suction for occupational health and safety. Some of the symptoms of mercury poisoning include leg cramps, itching, rashes, perspiration, rapid heartbeat, hypertension, fevers, irritability, personality change. There's the Mad Hatter from Alice in Wonderland. And insomnia, headaches, nerve dysfunction, chronic fatigue. As I said, we're most at risk as an occupational hazard, and that's why we've made rules about and precautions how to manage it at work. It's worth noting that you shouldn't, dispose your teeth or amalgams into the sharps container, because the sharps generally get incinerated to dispose of them, and when the amalgam is subject to heat, then that's when it goes into its nasty vapor form. So you're not supposed to sterilize. Some people sterilize teeth to give back to the patients, or for dental students who collect them to work on them. They shouldn't go through the autoclave. You can put them in X-ray fixer. It's generally what we do. And then it gets collected by proper waste management people. So there was talk of replacing mercury with gallium, but gallium causes an excessive setting expansion, more corrosion, and doesn't have very good handling properties. So it's a bit hippie to think that the amalgam in your teeth is causing all your health problems. And it's not uncommon, unfortunately. Places like Byron Bay all have, Byron has a lot of dentists that are all not only anti-amalgam but anti-fluoride and stuff too. Like I mentioned, unfortunately, sometimes professionals can promote the wrong sort of messages, which make our life harder sometimes too, to be educating our patients when they're hearing different things from different professionals. Those at particular risk of amalgam toxicity are obviously your fragile demographics, so children, pregnant women, immunosuppressed people, and the elderly probably. But numerous studies on pregnant women found no difference between dental personnel exposed to mercury frequently and females not occupationally exposed. So All these people reported that there was no evidence of ill health resulting from the use of dental amalgam, with the exception of relatively rare and well-localized allergic type reactions on adjacent mucosa. So I've got some pictures of that. Having said that, it's more common to be allergic to the ingredients in resin composites than mercury. So there's a good paper on that by Macret and Wall from the Journal of the California Dental Association in 2004. I can put that reference up for you. If you saw a lesion like this in the mouth, this is what, in my opinion, this is what soft tissue trauma looks like from people with really super dry mouths, like super hyposalivation. So the first thing I would check before making any assumptions about allergies or toxicity is there a trauma? Is there a physical trauma going on? So there tends to be an immediate sensitivity if there is a true allergy, and that reduces as the amalgam comes to its full set. So basically, if you identify a lesion like this and your patient has severe hyposalivation, then there's a few other things you can try before you go polishing or repolishing restorations that don't look that sharp. And if they don't have a dry mouth, then I would refer this to a dentist to have a look at if it's still there 2 weeks later. That's the golden rule with oral pathology. If it's still there in 2 weeks, send it along to someone else who knows better than you. So I was very impressed that you guys had heard of amalgam tattoos before. This is an interesting picture. I'm not sure if you guys know what an apicectomy is, but one of the complex and specialist forms of root canal treatment is where a root canal's been done but it's unsuccessful for whatever reason, and the endodontist makes an incision up near the apex of the tooth but through the buccal bone and the soft tissue there, and they do what's called a retrograde filling, where they basically do a filling on the apex of the tooth, which they can access from their surgical exposure. So in this case, this amalgam tattoo is because someone's done an amalgam filling on the apex of the tooth, basically through an incision in the mucogingival junction there. Other reasons for amalgam tattoo are if it gets condensed into the tissue, basically, or during extraction. Sometimes if there's little bits of amalgam breaking off while you're taking out a tooth, and that can get incorporated into the socket, and then when it heals over, it looks like an amalgam tattoo as well. This is important to be able to not diagnose necessarily, but understand as a differential diagnosis, because it can look a lot like a melanoma. Melanomas look quite dark like this, and it's the importance of having a radiographic view of something like this that you think looks a little suspicious, because obviously the amalgam's going to show up really radio opaque in your film, and a soft tissue pathology wouldn't show up at all. So that can be helpful. So it was predicted like 20 years ago that the environmental contamination of mercury production and wastage was going to be the main reason why it's phased out over time, which is exactly what's happened. And so the dental suction units have a special way of collecting the amalgam that gets sucked up in the suction, and it's mandatory to use the special amalgam traps in Victoria, but not in all states of Australia. Longevity. Again, The most common reason for failure of any direct restorative material is secondary caries. So if you can get on top of your patient's risk status, then your work will be more successful over time. That will reflect well on you, because good work fails in a dirty mouth and dodgy work lasts a long time in a clean mouth. There's lots of articles that you can read on longevity, and if you choose that for your case presentation, you'll have lots of reading to do. So, yeah, you can read about that in your own time. This is from Mountain Hume. Great textbook, by the way. Hope you all have access to it. There's a few chapters actually up on LMS there for your revision. Obviously, this would only happen in a low caries risk patient that was taking good care of these. So they actually look extremely good for 15 years old. There's another article that I highly recommend that you read called in the title is Implications for an Amalgamless Profession. And that is on LMS under Interesting Reading and Study Material on Amalgam. So definitely have a read of that. And we will go on to our next lecture next time I see you, which won't be until I think February or March. But stay tuned on LMS because I intend to keep posting stuff, and feel free to use the forums to ask me questions. You can also email me, and yeah, hope clinic is going well for you. Ciao for now.